Shank, I think we can start the meeting. It's already 3 o'clock.
Okay.
Dr. Suresh Babu is yet to join. I hope he'll be joining soon. So good afternoon, everyone. Dr. Paras ma'am, can you start?
Certainly,
It's already 3 o'clock.
Shall we begin with the first presenter?
I think presentations are.
Do we have all the people here?
Yeah.
Hi everyone. Thank you KOS for giving me this wonderful opportunity. So I'll be sharing my screen now. My topic for today is investigating a case of corneal ulcer. So what do you do when a patient comes to you from a very low socioeconomic background with this kind of picture? So any patient that comes to you, you take a thorough history regarding history of trauma, their occupation, if there is trauma with the animal tail, or if there is trauma with the leaf or branch of a tree, and so on. So after thorough history taking, you do a good slit lamp examination, and then you perform the investigations accordingly. So you document all the signs and symptoms in your slit lamp examination. You do a fluorescein staining to know the size of the infiltrate, to know the size of the epithelial defect, to know the pattern of the ulcer. You can also perform a rose Bengal stain if you are suspecting a geographic ulcer. You can do a lissamine green stain. And if there is a peripheral ulcerative keratitis, before coming to the diagnosis, you have to rule out infective pathology. You have to ask history of contact lens use. And not only the cornea, you have to examine the ocular surface, you have to examine the lids and the adnexa. You have to perform a Roblast test to rule out any lacrimal sac pathology. So based on your clinical examination itself, you can come to a gross diagnosis. For example, the fungal keratitis could be having feathery margins, it could be dry looking or pigmented like in the second picture. And if it's bacterial, it could be round or oval. If it is acanthamoeba, there could be a ring infiltrate with severe pain. Viral can show you a picture of a dendrite. And if the ulcer is very fulminant and rapidly progressive, it could be a pseudomonas infection. You have to perform a thorough fundus examination. And if it is not visible, you have to do a B scan to rule out endophthalmitis. Coming to the systemic examination. The basic thing that you have to do is rule out diabetes. And if you're suspecting a PUK, you can perform all this series of examination. So after investigation, you have to do syringing. As I told you, you have to rule out chronic dacrocystitis because if it is there, your ulcer is not going to heal. In fact, it is going to progress or even worsen and cause perforation. So it is very important you address the same. Coming to microscopy. So we perform scraping in all ulcers before we start antimicrobial therapy. So this serves as a diagnostic as well as therapeutic purpose. This is done under topical anesthesia using 0.5% proparacaine. You can perform under general anesthesia in children and people with mental retardation. You take the sample from the ulcer or from the conjunctival swab or from the lacrimal sac, or you can also perform a paracentesis and send for culture sensitivity. If the patient is on contact lens, you have to examine the contact lens as well as the contact lens solution. The most common instrument that we use is a 15 number blade in the OPD. So how do you do it? Firstly, you remove the mucus, debris and the slough that is on the ulcer, and then you scrape the base and the edge of the ulcer in a single direction. And then you send for smear. And once it is done, you do a thorough therapeutic debriding to debulk the infiltrate. Sometimes you may face difficulties in a small ulcer, which gives you insufficient sample. If it is a deep keratitis with intact epithelium, the ulcer won't be reachable for a scraping. And if there is desmetocele, there are chances that you will perforate it. So you do a wet mount of potassium hydroxide. You spread it out as thin as possible and then put few drops of potassium hydroxide, place a cover slip and examine under microscope. This is how a fungal pipette looks like. You can perform a gram staining to rule out the gram-positive and a gram-negative organism. Gram-positive organisms show purple in color and gram-negative shows pink in color. Sometimes you can find artifacts and you can get confused between gram-negative and positive if the staining is improper. So, proper staining technique has to be followed. If you have access to special staining techniques, you can perform Giemsa staining, Ziehl-Neelsen staining, and if you have fluorescent microscope, you can perform a Calcoflow white staining and also acridine orange. Coming to culture and sensitivity. This is the gold standard for any investigation. You can use a blood agar, Samuel's dextrose agar, chocolate agar, brain heart infusion rod, and many other culture methods. The main thing that you have to remember is you have to do this in a C-shaped configuration. It differentiates valid growth from contamination. So if the growth is on the streak, that means it is significant. If the growth is outside, that means it's a contaminant. There is something called as micro-ARD. It is an antimicrobial removal device. What it does is when you come across a patient who is already on antibiotic therapy, so even if you scrape, the test will be negative. The reports will be negative. So in these kind of patients, this device is used to increase the yield of positive cultures. So when do you call the culture positive? You call it positive when the growth of the organism in 2 or more media, or if there is confident growth of a known ocular pathogen in one solid medium, or if there is growth in one medium of an organism with a positive smear, or growth of the same organism in liquid medium. There is also a Jones criteria for the same. Clinical signs of infection with isolation of bacteria in one solid medium and on one additional medium, or isolation of fungi in any 2 media or one medium in the presence of a positive smear. You send this for antibiotic susceptibility testing. Based on this, you can customize your treatment. When do you call a culture negative? You call it when it is sterile, when the patient is already on therapy since long, when the sampling is inadequate, and when there is improper selection of media. So when the culture is negative, you stop all the medications for 24 hours and re-scrape and send it to lab. Corneal biopsy. You do it when everything is negative. This is basically a superficial lamellar keratectomy. You perform this under topical anesthesia. You use a 3 mm trephine. You punch it up to anterior stroma. You do a lamellar dissection. You remove it with a forceps. You cut it into multiple pieces and then send for examination. The main thing that you have to remember is avoid doing this in the visual axis. Coming to lab investigations. Other than the routine investigations, especially in viral keratitis, you can perform a PCR if you have access to it. It is faster than culture, but it is costly, and also it can give a false positive results. You can also perform immunological tests as and when needed. You can perform serum antibody titers. Basically, you take sample 5 to 7 days of the onset of symptoms. If it shows low neutralizing antibody, and the second sample, which is taken 3 to 4 weeks after symptoms, and if you find that there is 4-fold rise in titers, it is suggestive of a primary infection. In another scenario, if the first sample shows moderate neutralizing antibody and the second one shows 4-fold rise in titers, it is suggestive of a recurrence or a reactivation of infection. Coming to confocal microscopy, this detects organisms more than 15 microns. This is an image showing fungal hyphae and acanthamoeba cyst. Electron microscopy, it is gold standard of any imaging. So these are some images showing the bacteria, the fungal hyphae, and acanthamoeba. So to end this talk, I would like to tell you that with good clinical acumen, you can come to a gross diagnosis. You customize your investigation based on your clinical acumen and then plan your treatment accordingly. Thank you for your patient listening.
Very nice talk, very comprehensive. to cover all the aspects of investigation. I just wanted to ask one question about the device which was being used for, taking care of the, getting the more yield of the organisms. Can you just answer that question?
But Aparna, she's not there in the group.
Oh, sorry for that. And maybe when she's there, we can have that question.
Yeah, probably. But unfortunately, I'm hearing a lot of echo. Once we speak, after about 10 seconds, I'm hearing the same thing repeated. So just trying to find out what's the issue with my.
Are you logged in with two devices? Then this can happen.
Pardon?
If you are logged in with two devices, then
Okay.
Yeah, it's possible, sir.
So let me
if you are logged in with mobile as well as the laptop or a desktop.
Yeah, I just logged out of my
Just
mobile.
switch off one and that should be fine with you.
Okay, so it's clear now.
It seems to be better, right? Yeah. Shall we move on to the next talk then?
Okay, ma'am, shall I play the video, next video? Jairam
Yeah,
Bihar.
I guess you have all the videos pre-recorded, right? Except mine.
Yeah.
Yeah, so go ahead and then whenever somebody is there, present there, let us know, then we can discuss the, subject a bit. Yeah.
Sure. Vidya Shankar is not there, ma'am, yet. I'll play the rest.
Good afternoon, all. First of all, I would like to thank Karnataka Ophthalmic Society and Dr. Ellen for giving me this opportunity. Today, in this session, I will be talking regarding nuances in the treatment of viral keratitis. Herpetic eye disease is a very common problem, causing both asymptomatic infection as well as active disease in a wide variety of end organs. In the eye, it can affect all layers of the cornea. Epithelial affection usually starts as corneal vesicles, progresses to dendrites, and if left untreated, becomes a geographical ulcer. All these manifestations have typical features. Only marginal keratitis, which is atypical and can be confused with the local marginal infiltrate, which can be differentiated by the following features. Etiologically, HSV marginal keratitis is an active infection by the virus, and staphylococcal marginal infiltrate is a immunological response. HSV marginal keratitis, the epithelial defect is always most of the times is present, which is absent in staph. Neovascularization is present in HSV, it is not there in staph. In HSV, the progression is from periphery to central, which is circumferential in staph. Staph is associated with blepharitis, which is not there in HSV. HSV location can be in any meridian. In staph, it is typically 2, 4, 8, and 10 o'clock meridians. In HSV keratitis is typically a response to antiviral treatment, and the staph margin infiltrate to topical steroids. Coming to antiviral agents for HSV, guanosine analogs are the most important group of drugs, in which acyclovir is the most important drug being used. Acyclovir acts by inhibiting viral DNA polymerase. Valcyclovir is another prodrug which is has better bioavailability. Ganciclovir is also another guanosine analog, which is as a more broader spectrum because it is phosphorylated by not only by viral thymidine kinase but also by other mediators. Acyclic nucleotide analogs like cidofovir and pyrophosphate analog foscarnet are also effective in HSV, which can be used in acyclovir resistance or when there is associated CME infections. In HSV epithelial keratitis, the treatment is dental debridement, a cyclover 3% ointment 5 times for 2 to 3 weeks. Ganciclovir 0.15%, 3 hourly for 1 week, and then 3 times for 1 to 2 weeks. If the epithelial defect is persisting beyond 2 weeks, you should suspect antiviral toxicity, and it's better to switch to systemic acyclovir. Newer drug targets are helicase and primase inhibitors, which has other viral enzymes. And some candidate drugs like Bay57 has shown some effectivity more than acyclovir in animal studies. Toll-like receptor antagonists, which increases the innate immunity, which also has shown some promise. Therapeutic vaccines like Glasgow's Simplirex Herpivac is in phase 3 trial. Coming to neurotrophic keratopathy. In neurotrophic keratopathy, typically it will be asymptomatic due to the corneal insensitivity. The 3-stage classification by Mackey will be useful in planning the treatment. The aim of the treatment is to restore corneal integrity and prevent progression. A step-ladder approach based on severity is the line of treatment. In Mackey stage 1, there will be punctate epitheliopathy with epithelial hyperplasia and mild erosions. In such cases, avoid or discontinue epithelial toxic systemic and topical drugs. Then address concurrent ocular surface problems like dryness, copious use of preservative-free artificial tears, and punctal occlusion can be tried in cases of severe dry eye. In Mackey stage 2, there will be recurrent or persistent epithelial defect with superficial stromal involvement. In the stage 2, preservative-free prophylactic antibiotics are to be started, along with the collagenase inhibitors like vitamin C and tetracycline. Autologous or cord blood serum or platelet-rich plasma, which has growth factors along with cytokines and vitamins, are also effective. Therapeutic contact lenses, tarsography, amniotic membrane graft, and conjunctival flap can also be tried in cases which are not responding. In Mackey stage 3, there is a corneal ulcer with thinning, melting, and possibility of perforation. In such cases, multi-layered AMG and tissue adhesive DCL are tried, and in cases which progresses tectonic or full thickness, corneal grafts are indicated. Newer treatments like Sinigermin 0.02%, that is recombinant nerve growth factor, which is available as Oxervate in UK and US for clinical treatment, but it's prohibitively costly, around $23,000. But 8 weeks treatment has shown significant improvement in multiple number of studies. And corneal neurotization, it can be either indirect or direct by transposing supratrochlear or supraorbital nerves, or indirect by transplanting from sural nerve has also shown promise. Coming to stromal keratitis, can be either necrotizing stromal keratitis or immune stromal keratitis. Necrotizing stromal keratitis is infective HSV infection of the stroma, which causes ulceration, dense infiltration with overlying epithelial defect. It can cause thinning and perforation in short time. It resembles infectious keratitis secondary to microbial invasion. Immune stromal keratitis is due to retained viral antigen in the stroma, which incites antigen-antibody complex cascade, which leads to the stromal inflammation and neovascularization. Treatment is oral acyclovir in prophylactic dose with hydroprednisolone 0.05% in tapering dose for 10 weeks or tailored according to the response. In cases with ulceration that is necrotizing type, acyclovir should be started in a therapeutic dosage. Coming to HSV endotheliitis, which can manifest in 3 forms, that is disciform, diffuse, or linear. Disciform type, the keratic precipitates are distributed in the central or paracentral cornea with a circumscribed corneal edema. Surrounding cornea is relatively spared, which is responsive to topical corticosteroids. In diffuse type, the KPs are scattered all over the endothelium, as well as stromal edema is also involves the entire cornea. It responds to topical and systemic corticosteroids, and antivirals will lead to resolution. The third type is linear endotheliitis, in which a line of KPs progress from the limbus to the central. It can be either sectorial or circumferential. The edema is always peripheral to the line of KPs extending to the limbus. This can also happen in post-cataract patients who have previous HSV. This is actually more aggressive type among the 3, which requires aggressive treatment with topical and systemic antivirals and corticosteroids. And in such cases, corneal decompensation possibility is more than the other 2. The treatment is oral acyclovir 400 mg BD, and as I explained earlier, herpetic eye disease is a landmark study which I've given several insights into the treatment of HSV eye disease. We'll go to the primary conclusions. The HSV studies 1 and 2 have 5 arms, and it have the primary conclusion of HEDS SKS study is oral acyclovir is not useful as adjunctive therapy for stromal keratitis, and topical steroids is useful in treatment of stromal keratitis. For epithelial keratitis, oral acyclovir has no apparent benefit. Oral acyclovir significantly reduces the risk of recurrent disease by approximately 50% and is recommended for long-term prophylaxis, especially for recurrent stromal keratitis. Also, oral prophylaxis should be considered on an indefinite or long-term basis for high-risk patients, including those with a history of recurrences, atopy, corneal transplant in the setting of previous HSV or immunocompromise. It is also reasonable to start oral antiviral prophylaxis and schedule ocular surgeries till topical steroids are tapered up. To summarize, for epithelial keratitis, topical antivirals and oral antivirals in cases of antiviral toxicity, and in stromal ulceration, stromal disease without ulceration, that is immune stromal, antivirals in prophylactic dose plus topical corticosteroids, and in stromal disease with ulceration, that is infective type or necrotizing type, antivirals in treatment dose plus topical corticosteroid, and in endothelial type, all the 3, disciform, linear, and diffuse, antivirals treatment dose plus topical corticosteroid as explained earlier. Thank you.
Thank you, Dr. Jairam. Krishna, can you play the next speaker's
Sure.
presentation? I think Dr. Suresh Babu's presentation.
If we have something to ask, can we ask now or?
Yeah, I think now we can ask. Dr. Jairam is there.
Okay, sir.
You can unmute and then
Yeah.
answer.
In cases of recurrent viral keratitis, especially involving the visual axis, if you consider keratoplasty, how long would you prefer to give oral antiviral prophylaxis, sir?
Jairam, would you like to answer?
Yeah. In recurrent viral keratitis, definitely antiviral therapy needs to be continued. In epithelial keratitis, up to 2 to 3 weeks, we can continue the antiviral topical antiviral therapy. If it subsides, we shall discontinue it. But usually in epithelial keratitis, after when the treatment is effective, it will resolve with mild stromal scarring. It won't cause much of a visual disability. But in stromal
Jairam,
keratitis,
I think the question was regarding the post PK, post keratoplasty. How long would you like to continue antiviral therapy?
okay, in post keratoplasty, when there is a recurrence of keratitis. I didn't get the question correctly.
Rupasri ma'am, can you again rephrase the question once again?
Yeah, my question was how long you will give antiviral prophylaxis in a case if you have done keratoplasty for recurrent viral keratitis involving visual axis. I mean, for visual rehabilitation, if you have done keratoplasty, how long would you prefer to give antivirals, sir? Oral.
Yeah, it is recommended to give at least for 1 year. But in the hepatic eye disease study also, it has mention is there if antiviral prophylaxis is stopped, then the effect of the that will also won't be there after that. So at least you should give for 1 year and then observe. If there's any kind of recurrence, if you observe, then you will have to restart and continue. And in and that's regarding the post keratoplasty and recurrent stromal keratitis. You will have to continue for 1 year and then stop and see. Then if there is recurrences again, then you will have to continue after when you are giving it for a long time. Then you will have to do renal functional tests and make sure that there is no toxicity happening.
Thank you, Dr. Jairam. Dr. Shashank, can you play the next presentation, please?
Good afternoon, everyone. I would like to thank KOS for inviting me to speak on bacterial versus fungal keratitis management strategies. My topic today is bacterial versus fungal keratitis management strategies. This is Ophthalmic Hospital, which has completed 125 years of its service. In any infectious keratitis, the management goal is resolution of infection, whereas the desirability is restoration of vision. Factors that affect the management of infectious keratitis include systemic issues like diabetes mellitus, immune status, connective tissue disorders. Local issues like lacrimal sac problems, dry eyes, lag of thalamus, trichiasis, spheroidal degeneration. Lid issues like lid margins, lid closure, entropion, ectropion, meibomianitis. Usage of contact lenses also affects management of infectious keratitis. Sometimes use of local medications or alternative medications by the patients also affects infectious keratitis. There might be abuse of topical steroids by the patients. Don't miss out corneal sensations, congenital scarring of papillae, and several issues. Stains and culture form an important part of management of infectious keratitis. Wherever possible, try to do bacterial or fungal stains along with the culture. Remove the slough and necrotic material and use it for the stains and culture. Corneal scrapings are usually done with 26 or 23 gauge needles and sometimes with surgical blades. Grams and Giemsa stains are used for bacterial keratitis. The KOH wet mount is used for fungal keratitis. Gram stain and Giemsa stain can also be used for identifying the fungus. Calcofluor white requires an autofluorescent microscope. Blood agar and chocolate agar are used for the growth of bacteria, whereas Sebrod dextrose agar is used for fungal growth. If you are suspecting acanthamoeba, use non-nutrient agar with E. coli. Slit-lamp biomicroscopy forms an important and integral part of management examination of infectious keratitis. Use it to define the borders of the ulcer, the depth of the ulcer, involvement of other structures if any. If it's an already treated ulcer, look for either healing edges or the progressive areas or even maybe drug toxicity. Always record your signs and before beginning treatment. Daily recording of the case using color codes and cornea charts will be helpful. Digital photography helps in objective assessment. These are the cornea charts that are used for infectious keratitis. General measures in the management of infective keratitis. Anticollagenous drugs like doxycycline helps in corneal melts. Anti-glaucoma drugs like Dimox and Timolol are used. Cycloplegics that are used are atropine and formamide. Anti-inflammatory drugs like paracetamol, ibuprofen, and indomethacin are used. Preservative-free lubrication, especially in bacterial keratitis, are used. Bacterial keratitis diagnosis is very simple. Usually there will be a flat and severe hypopyon. The pain is very severe. Perforation is more common if it's untreated, especially in pneumococcus and pseudomonas. Ring ulcers are seen in pseudomonas, and if it is untreated with melting of the cornea and greenish and yellowish mucopurulent discharges seen. If gas bubbles are seen in the epithelium, stroma, and anterior chamber, it indicates Clostridium infection. Staphylococcal ulcers are seen in compromised corneas such as bullous keratopathy, chronic herpetic keratitis, dry eye, rosacea keratitis, and atopic disease. Moraxella ulcers occur often after trauma in debilitated patients, alcoholics, diabetics, and chronically malnourished patients. Nocardia and Mycobacterium ulcers produce a cracked windshield appearance. Neisseria, Cornybacterium, Haemophilus, and Listeria are the organisms which can invade the intact cornea. This is an infectious keratitis. Looks like with a flat hypopyon, Descemet's folds suggesting of impending perforation. The ulcer is in the periphery. Looks like a bacterial corneal ulcer. Any ulcer which is treated properly will result in a corneal scar, which is the desirable option. If untreated, an ulcer can progress to become a suppurative lesion, and finally it can melt, causing a perforation, which may end up requiring tectonic keratoplasty. Treatment: uncomplicated bacterial corneal ulcer. Topical treatment: initial empirical therapy can be done. Fortified ceftazidime and fortified tobramycin are the drugs which are used for gram-positive and gram-negative organisms. Or broad-spectrum fourth-generation drugs like moxifloxacin and gatifloxacin eye drops can be used. Later, you can change the antibiotics according to the culture and sensitivity report. Systemic treatment is mandated in case of Neisseria infections, may be given in fulminating cases, and if there is adjacent scleral extension. Subconjunctival drugs are given if there is poor compliance to topical treatment. Topical steroids are not recommended in case of bacterial keratitis. If there is an impending perforation, we advise the patient to avoid strain. We can prescribe pressure lowering drugs like timolol or dime tablet Dimox. Tissue adhesives like cyanoacrylate glue or fibrin glue can be used. Amniotic membrane transplantation can be done. Tectonic or therapeutic penetrating keratoplasty should be done if it is not amenable to glue. This is a case where a small perforation, glue was applied, and the end result is a well-healed corneal ulcer, which didn't require a keratoplasty. If the perforation is very large, then therapeutic or tectonic penetrating keratoplasty is mandatory. If done with a good tissue, the results are excellent. Fungal keratitis. Fungal keratitis are divided into filamentous fungus and pigmentous filamentous fungi and yeast. Non-pigmented filamentous fungus are Fusarium and Aspergillus, whereas pigmented filamentous fungus are Curvularia and Alternaria, and among the yeast they are Candidiasis. How are fungal keratitis identified? Symptoms are less marked when compared to signs. Course of the disease is very slow. There will be stromal infiltrates with feathery hypate edges. Infiltrates are dry, gray, elevated, and above the level of the corneal surface. Satellite lesions, endothelial plaques with fungal elements in the antechamber are present. Immobile hypopyon, which is convex shape. Wesley's immune ring may be seen in case of stromal keratitis. Treatment. Debridement is very important and mainstay of the primary treatment. Antifungals, topical natamycin 5% or amphotericin B 0.15%. Oriconazole eye drops 1% for better penetration in deep stromal and antechamber infections. Fluconazole eye drops 0.3% are used for candidiasis. Systemic treatment is done in case of severe and deep keratitis, endothelial and antechamber infection, scleritis, endophthalmitis. Liver function tests are to be monitored during the management of systemic treatment. Ketoconazole 200 mg BD, fluconazole 150 mg BD, itraconazole 100 mg BD, posaconazole, luconazole, clotrimazole, and amphotericin B can be used. Intrastromal injections like oriconazole and amphotericin B are also used as intracameral injections. Preservative-free oriconazole and amphotericin B can also be given. Glue, cyanoacrylate or fibrin glue is used, but it is very rare because perforation is very rare in fungal keratitis. In non-responding ulcers, therapeutic penetrating keratoplasty is done. Few tips for management of fungal keratitis. Make sure that the natamycin sticks to the surface of the ulcer. That is one of the tips. Second tip is natamycin is not required after therapeutic penetrating keratoplasty, as there will be no surface infection. This is a case of fungal keratitis. You can see the feathery edges, dry, elevated surface, and here is a KH wet mount which is done, showing the filamentous fungi. This is a case of fungal keratitis where debridement has been done. We can see how well debridement will help in debulking the disease. A case where even the pupil was not seen after debridement, you can see 90% of the infectious keratitis has been taken care of. So kindly practice debridement in all cases of fungal keratitis, which will help in a major way in treating the ulcer. Thank you.
Thank you, Dr. Suresh Babu. I think Dr. Suresh Babu is not there. The group right now is not joined. We can go to the next presentation.
Sir,
Rupashri.
before starting my presentation, can I
For
ask?
giving me this opportunity.
Yeah, you can give
The
it.
topic of presentation is Acanthamoeba keratitis. It is ubiquitous microorganism which is an opportunistic pathogen in humans. The first case was described in 74 in UK and in India in 1990. The Western literature shows the contact lens as the most common predisposing factor, but trauma, exposure to contaminated water and soil being the most common in India and other developing countries. It accounts for 2% of all cases of culture positive ulcers at tertiary eye care centers. The typical clinical features are disproportionate pain, radial keratoneuritis, which are inflamed corneal nerves with the inflammation of the adjacent stroma, and ring infiltrate, which is a pathognomic sign. But one must remember that these typical clinical features are not present in all the cases. There is highly varied presentation of Acanthamoeba keratitis. When it presents with the classical features, it is easy to diagnose. It is not surprising to misdiagnose as viral keratitis when it presents as epithelial lesions, and fungal keratitis when it is presenting as stromal infiltrate, and treat them accordingly. So when to suspect Acanthamoeba keratitis? Patients presenting with corneal infiltrates associated with inflamed corneal nerves, or chronic keratitis associated with ring infiltrate, or suspected HSV keratitis not responding to anti-HSV therapy, or maybe ulcerative keratitis not responding to antibacterial or antifungal therapy. The diagnosis is done by clinical features and lab evaluation. Laboratory methods involve conventional and molecular methods and in vivo confocal microscopy. As per the routine protocol, conventional methods include smear and culture. 10% KOH mount is the simplest and quick method to diagnose Acanthamoeba keratitis. Grams and Giemsa stain will take little more time. Calcofluor white needs fluorescent microscope. Culture should be done with the inoculation of the speculum on non-nutrient agar with E. coli, which may take 1 to 3 days of time. Culture should not be concluded as negative for up to 2 weeks. Biopsy is recommended when smear and culture is not showing any organism, or when the infiltrate is very deep and inaccessible for scraping. Different staining techniques are described for biopsy histopathological examination. 10% KOH mount and culture show Acanthamoeba cysts as polygonal double-walled structures. The cysts are seen here in gram stain, Giemsa stain, NNA with E. coli. These are the migrating tropozoites on NNA to feed on the bacteria E. coli. Molecular methods involve PCR and newer method 18SR-DNA, which takes less time and simple than PCR, but PCR is highly sensitive and specific. In the past decade, there has been a lot of focus on in vivo confocal microscopy, which is a non-invasive imaging technique which produces direct visualization of pathogens in fungal and Acanthamoeba keratitis. It is very useful technique for deep infiltrates inaccessible for scraping. It provides instantaneous diagnosis with high accuracy, but it all depends on the experience of the examiner. When the cluster or chains of Acanthamoeba cysts are present, it favors poor prognosis. Cysts are seen as double-walled, hexagonal, hyperreflective structures, and tropozoites as pear-shaped structure with surrounding halo, which are difficult to differentiate from normal keratocytes. Inflamed corneal nerves can also be appreciated. Coming to the medical management, there are no formal guidelines or standards of care for the treatment of Acanthamoeba keratitis. The goals being eradication of viable cysts and tropozoites, rapid resolution of the associated inflammatory response. Wide variety of chemotherapeutic agents show in vitro susceptibility for the organism. But when it comes to in vivo cysticidal activity, biguanides and diamidines are the best, which are shown here in this table. A combination of PHMB and chlorhexidine 0.02% is preferred as the primary therapy. Intensive early treatment is required before the cysts mature. Average duration of medical therapy in various studies in literature is around 6 months. One must be cautious about the toxicity of the drugs as the treatment is prolonged. Successful treatment of chronic stromal keratitis with Oriconazole, topical, intrastromal, and oral is reported. Recently, topical Oriconazole as monotherapy was studied by Bagga et al., and they concluded that it is effective and comparable to biguanide combination therapy. Miltefosine is antimicrobial, antiparasitic, antineoplastic drug used to treat leishmaniasis, and it has been approved by US FDA for the management of Acanthamoeba keratitis in humans. Systemic administration of miltefosine in hamsters and rats were effective. So inspired by this, Bagga et al. Conducted a study with topical miltefosine as monotherapy in the formulation, and they concluded that it may not be effective as a primary therapy for Acanthamoeba keratitis, which is shown here in the picture at presentation, and worsening of the clinical features at 1 week after treatment. There is a lot of ongoing research with targeted delivery and novel targets being identified, but the translational value for therapeutic intervention requires further investigation. Lot of literatures discuss about the role of steroids, which is controversial. It is beneficial for the control of inflammation. In laboratory, steroids will transform cysts to tropozoites, but there is a risk of worsening or recurrence of disease also. So one should continue biguanides after the discontinuation of steroids. The main indications for steroids are occurrence and progressive increase in deep vascularization of cornea, inflammatory complications of AK involving sclera and anterior chamber, severe out of proportion pain. Collagen cross-linking was studied extensively in systematic review and meta-analysis by Dua et al., and they concluded that there is insufficient data in literature to perform any meaningful analysis for Acanthamoeba. Interestingly, when riboflavin was substituted with rose bengal, PAC-CXL was shown to demonstrate effective anti-amoebic activity. With lot of efficacy, high efficacy with the medical management, surgery should be largely avoided in active cases and fulminant cases. So the current indications for surgery are large infiltrate extending to involve the limbus, worsening on medical treatment, and gross thinning or actual perforation. Prefer penetrating keratoplasty in perforations. Dark has better prognosis for eradication and graft survival when it is done in early cases. When it is done in advanced cases, it has less favorable outcomes, as shown in this picture, with the clear graft post-operatively done for early cases and recurrence of infection in graft done in advanced cases. Complications are many, mainly cataract, scleritis, and intraocular split. The management differs. So the take-home message is Acanthamoeba is ubiquitous, diagnosis and treatment are difficult. Important step in diagnosing is to suspect it. KOH mount is the simple and quick lab test for diagnosis. Early and prompt treatment is essential to secure good prognosis. Thank you.
Thank you, Dr. Rupashri ma'am. Before we start the next presentation, if there is any queries or any comments, we can have it now. Dr. Rupashri ma'am, before the presentation, you were saying something. I think the presentation started abruptly.
Yes, sir. I had 1 or 2 questions which I wanted to ask in this forum. If you give me time, I'll ask now. Otherwise, I'll ask at the end of the forum. I mean,
Probably at the end of the session, we can have that. Huh?
Yes.
But now we move on to the next much awaited talk, the keynote address about the case of non-healing corneal ulcer. Sure, we would have seen a number of cases, non-healing, healing, and suddenly they become irresponsible, not responding to the treatment. Dr. Paras ma'am, please guide us how to manage such cases.
Before that, I would like to congratulate Rupashri. She presented a very nice review of latest management of Acanthamoeba keratitis. Shall I start sharing the screen?
Yeah, I think so.
At the outset, I would like to thank the Alan Kumar, dear friend, and the KOS managing committee for having me here for this your academic forum. Can you see my screen now?
Yes, ma'am, very well, we can see it.
Yeah, that is fine. So like it is definitely a kind of, an honor and opportunity to be here with you all today. So my talk today is an approach to a non-healing corneal ulcer. My previous speakers have made my talk much more easier because there was a presentation on bacterial keratitis, fungal keratitis, describing classical features and all, even acanthamoeba. And there are subsequent presentations also which would take care of some of the part of my talk. So the question here is, when do we call an ulcer to be, non-healing? An ulcer which does not respond to management strategies. And I'm getting a black view here. Okay, yeah. Either the diagnosis is missed or it is misdiagnosed. So non-healing corneal ulcers can comprise of, it could be infective or non-infectious. Amongst the infective non-healing corneal ulcers, it could be bacteria, fungus, viruses. Amongst the bacteria, the most common are Pseudomonas and Staphylococcus, but there are various other bacteria which were listed in the previous talks. The fungus, classical, we would, come across, the Fusarium and the Aspergillus, but there are many others which are relatively rare, and the viruses, HSV and herpes zoster. The rarer infective organisms could be acanthamoeba, nocardia, microsporidia, atypical mycobacteria, and pythium. So when you are suspecting common, ulcers, and it is not responding to your medical management, and there is an atypical presentation, one should also keep in mind the possibility of rare infections like acanthamoeba, nocardia, microsporidia, and atypical mycobacteria, or in recent times, pythium keratitis as well. Amongst the non-infectious groups, it could be autoimmune, it could be neurotrophic, which was very well described in the talk of viral keratitis. Following trauma, it can occur following chemical injury. Toxicity or medicamentosa also can lead to non-healing corneal ulcers. Allergic keratitis like vernal, keratitis secondary to entropion or blepharitis, and host of other causes as well. So the most important part, how do we approach these patients? The first important part is talk to your patients. This was very highlighted in the first presentation, that it is imperative to take a detailed history which can help identify the ulcer's etiology. Like you ask the patient, how much pain do you get? Or, what kind of pain he or she is getting. A bacterial ulcer patient would have a very severe pain. Similarly, an acanthamoeba patient would have a very excruciating pain as against a fungal ulcer. And a patient having, neurotrophic keratitis or viral keratitis may not really show or tell, may have so much pain. So you would be able to differentiate even from there on. Duration of symptoms, environmental or social factors, like somebody is working in a chemical environment, or a patient is using a contact lens wearer. Even an ocular history, whether there were past episodes of similar attacks, which would also clinch the diagnosis towards the viral possibility. Presence of old corneal scar, any previous ocular surgery, any history of trauma, recent ocular medications, so that you would know that what you are dealing with. And systemic history of diabetes mellitus, rheumatoid arthritis, or any other collagen vascular disease would be very, very important to get. Then followed by that, one would proceed with the examination of the eye. Look at the size and location of the ulcer, whether it is central, paracentral, or peripheral, whether there is an epithelial defect. Some infiltrates may have an intact epithelium over the infiltrate, which may also, talk about, the presence of either a fungus or a viral infection. But there may be deep-seated infection, which may be even bacterial and which may be epithelialized. Presence of any stromal necrosis, which generally, clinches diagnosis of bacterial keratitis. Look at the margins of the ulcer. Presence of endoexudates or characteristics of hypopion also would lead to some information, and corneal sensations. Microbiological workup is also very important part of the workup of any non-healing corneal ulcer. With the advent of fluoroquinolones, we all tend to use, first line management as for any ulcer, we use it as a first line management. And in most of the cases, it would help in healing the ulcer. But there would be cases where you would like to do a microbiological workup before subjecting these patients for empirical management or broad spectrum management in terms of fluoroquinolones. These are the cases if they are not treated in time, or if we do not have any information about the organism, they can go downhill course. So one should always consider microbiological workup if the ulcer is central and larger than 2 mm in size. Prior to any initial management, one should take the scrapings. If you do not have an access to culture media, you can still get valuable information from a gram stain, which was very, very nicely highlighted in a previous talk. So let's look at some of the clinical situations. In this, clinical picture, you try to recognize typical clinical features, especially whether it is bacterial or fungal. If it is looking bacterial with, very rounded, well-defined margins, and if there is a surrounding infiltration of cellular infiltration, as you can see here, polymorphonuclear infiltration, little surrounding edema, maybe you could, all right with starting with topical fluoroquinolones in a proper frequency. It's important to have a frequent dosing, like 1 hourly or 2 hourly, depending on the type of ulcer you are dealing with. And it's very mandatory that you call these patients for frequent follow-ups. At least you have to see them after starting the antibiotics or antimicrobials in first 24 hours, and then based on how they are responding, more frequently. So if I describe about the timeline, maybe call them after 24 hours. If you see there is no worsening, then maybe you call them after a day or two, so that you watch the progression, or this is the time when the ulcer would consolidate and the patient would start feeling better. The surrounding inflammation would go down. Even if there is no significant decrease in the infiltrate, the patient would start feeling comfortable, and you would be able to see that there is no further worsening into the infiltrate. And sometimes we may see decrease in the size or the decrease in the density of the infiltrate. If the patient does not show any improvement in 24 to 48 hours, always consider a micro workup. Or at times one should add or switch to the fortified drops instead of fluoroquinolones. Look for the compliance also. That is also very important. Many times we may have prescribed the drops every 1 hourly, and patient may be using it just 2 times or 4 times a day. Rule out all the other risk factors or contributing factors like diabetes mellitus or other systemic disease or leg of thalmus or any prior steroid usage, etc. Poor compliance to therapy can lead to failure to respond, and resistance to antimicrobials, like if you're dealing with MRSA, it can also be a possibility. So you have to keep this in mind. So if it is treated well with just a monotherapy, you can have this kind of a improvement, provided it is a bacterial ulcer and it is responding to the management, and you can definitely have a nice small thin stromal scar following a healing. The question is when to repair these cases. Typically, when an ulcer presents, one would start the patient on topical fluoroquinolones. If there is no response, the patient is referred to either a cornea specialist or to an academic institution for further management. And many of these patients, as I emphasized earlier, also they would go downhill course, even if it is just 2 millimeter, infiltrate to begin with. If it is a very fastidious organism like Pseudomonas or something, it would progress very fast in a couple of hours. And if you don't see these patients very often, probably you may end up losing the eye. So an immediate referral is needed if the ulcer is larger than 2 millimeter and located directly on the visual axis, if there is stromal melting or anterior chamber inflammation, or there is limbal or scleral involvement. So these are the red flags where you have to be a little careful. Any suspicious or atypical presentation also should be considered for strong referral. Like if the presentation is at this level, definitely this kind of presentation would require management by somebody who is well oriented to the corneal workup or has access to the microbiological lab workup, etc., etc. So sometimes such patients are referred to us, or they seek multiple opinions. As for example, this patient. Now we would just take some clinical cases and we will finish with that clinical scenario. There is a history in this particular patient. There was a history of fall of a foreign body in his left eye while riding the two-wheeler. He was initially treated with monotherapy elsewhere for first 20 days. He did show some improvement, and then gradually the ulcer became stationary. As you can appreciate here, there is slight improvement into possibly the size of the infiltrate, which must be there earlier, but then it became stationary, and hence the patient was referred. He was using moxifloxacin, tobramycin, and natamycin hourly. So what did we do differently? Like, we subjected him for microbiological workup. We found out that on gram smear, there were GNVs and occasional GPCs, gram-negative bacilli and gram-positive foci. There was no fungus. So there was no point in continuing, antifungal management. So you can definitely take away the antifungal management from the management protocol, so that, you don't end up into the toxicity onto the surface. We switched to fortified drops because he stopped responding to monotherapy, and the ulcer started responding, and you can see that the eye became quieter. And this is a picture after 1 week. You can see a larger area of, peripheral corneal scarring, and the infiltrate has become less denser, and probably it is healing. This is another example. 40-year-old female presented with redness, pain, watering in the left eye for 1 week. She used some drops for 2 days, probably query steroids. She was a known diabetic, was on moxifloxacin eye drops 5 times a day, natamycin 5% eye drops 3 times a day, and her vision was in terms of hand movement and counting finger close to face. So what was, something which would, lead to a non-healing corneal ulcer? Number one, patient was earlier probably used steroids. That worsened the situation. And sometimes when you stop the steroids, there may be flare-up of the inflammation. And that can lead to, increase in the size of the infiltrate. So we have to warn our patients about that. She was a known diabetic, so naturally that needed to be controlled. And moxifloxacin eye drops were being used in the frequency of 5 times and natamycin 3 times, which is a very, very low frequency, a homeopathic dose. So what did we do? It turned out to be obviously clinically classical fungal ulcer, but you do scrapings and you find out that there were, septic fungal filaments into the smears, and the fungus grew, Aspergillus fumigatus, and eventually she responded to medical management. For fungal non-healing corneal ulcers, it is important that you have to use antifungal agents for a very, very long time. You can't taper it very fast. And you have to use it for a very long time, and you have to keep debriding the surface as and when it gets epithelialized. So you can see a nice corneal scar eventually, and the patient healed very well. Sometimes late presentations may not have classical clinical features, as you see here, to categorize them, and hence a microbiological support becomes mandatory. This patient, worsened in 2 days to this level, and despite, microbiological workup and antifungal, she turned out to be fungus positive. It went on from this level to this level within a couple of days to 1 week. So she needed a large tectonic therapeutic graft, left lateral tarsorrhaphy to salvage the eye, and it turned out to be a fusarium species on culture and histopath. Prior to presentation to us, he was treated for 1 month. So this is the ultimate result of the ulcer. Sometimes atypical presentations can, be there. Like, you can see that there is a beaded wreath-like complete or incomplete wreath-like presentation, and that can lead to a diagnosis of presence of possibly nocardia. Or sometimes you may come across atypical Mycobacterial Keratitis or Pythium Keratitis. This picture shows a partially responding, Acanthamoeba keratitis with the classical Acanthamoeba ring. Unfortunately, I could not put the other, classical clinical pictures here because of paucity of time, which was given to me earlier. So this is another case who presented with history of redness, pain, and watering 2 weeks prior. He was found to be on moxifloxacin eye drops every 2 hourly and without much improvement on the treatment, and he was referred to us for further management. You can see a nice infiltrate surrounding edema and lot of, Descemet's folds and a small hypopion there. But if you look at the history, he was working in a chemical factory, so he had an exposure to chemical fumes as well. And when we examined him, you can see that he, on gross examination, he had leg of thelmus. So probably that was the reason why his ulcer was not responding despite the intensive medical management. So he had a compromised ocular surface because of exposure to chemical fumes, inadequate dosing of the medications, and one needs to address the leg of thelmus along with medical management. Otherwise, these ulcers would never respond. So he needed a tarsorrhaphy along with medical management. This is another example of a patient who presented with a history of pain, watering, photophobia for past 4 weeks. He was on topical fluoroquinolones and lubricants and cycloplegics, and he was referred for further management. When we asked him, he had a history of right-sided herpes zoster ophthalmicus few years back. As he was treated by a dermatologist at that point of time, he did not think it to be relevant for this particular, episode. And so we were dealing with neurotrophic keratitis, and these are the cases who would need different management approach. He underwent a tarsorrhaphy, and with topical lubricants and tarsorrhaphy, helped achieving a stabilized ocular surface in this neurotrophic corneal ulcer in case of herpes zoster ophthalmicus. This is another example who presented to us like this. He was treated elsewhere. There was a history of viral fever, following which he developed acute keratitis and later developed facial palsy, leading to leg of thelmus and non-resolution of the ulcer despite intensive management with antiviral therapy by the previous ophthalmologist. So a tarsorrhaphy along with medical management helped in healing the ocular surface in this particular case also. So it's very important to talk to your patient, to examine to do a clinical examination, get familiarized with the classical clinical presentations, and move on with the management part. Here is a young, a female child, a 11-year-old child who presented to us with history of off and on redness, watering, photophobia for past 4 months. And she was found to be on multiple, treatment, and she was referred for a probably therapeutic graft because she almost developed a desmetocele. As you can see here, the cornea has become much thinner, and the central part is showing a desmetocele. But here, what did we do? We realized that patient was on multiple drugs, so we withdrew everything. We put the patient on epithelial-friendly medications, and we also talked about possibly doing a tarsography. But by the time I started following up this patient after stopping everything, the ocular surface started showing an improvement, and we continued with the medical management, and without even doing a tarsography, she completely healed. And you can see that the cornea has healed, responded so very well. So it's important to even rule out, medicamentosa. This is another example of a nice clinical case. He's a 51-year-old male patient. Probably this is the last case. 51-year-old male patient who presented with redness, watering in the right eye for 2 months. He was on topical lubricants, drops and ointments, and topical antibiotic drops. He said that he was a bit better symptomatically on treatment, but came for second opinion. And he was having, recurrent breakdown of the epithelium and at times, stromal involvement as well. When we asked about detailed history, he gave a history of undergoing RF treatment for right-sided, headache that he had undergone, radio frequency treatment for trigeminal neuralgia, and that must have led to, anesthetic cornea. So the symptoms started after 15 days of the surgical procedure, and he definitely needed a tarsography, and the ulcer started healing well, and eventually the stromal haze also decreased, and he improved to 6.6. Later on, he underwent a cataract surgery a few years down the line, and again we continued because the corneal sensations were absent, so we continued with a partial lateral tarsography even after cataract surgery. So for non-infectious ulcers, it is important to recognize and treat the etiology. There are few, tools which are available to us are bandage contact lens for temporary purpose, a tarsography, an amniotic membrane application, which can be used either as a single layer or as multi-layer. One can also use, if there is a perforation, a Tenon's patch graft, or one can use a corneal or a corneoscleral patch graft. And one can combine more than one modality to get the best outcomes apart from the medical management in these non-infectious corneal ulcers. Unfortunately, I couldn't manage to put the videos or the other cases of non-infectious ulcers for this PPT because I was just finishing it till last moment. So to summarize, it is important to take good history with good clinical examination, looking at all the possible risk factors and try to fit in all the elements of the jigsaw puzzle to reach to the correct diagnosis. Early referral in non-responding cases would help get better outcomes in these cases. And each ulcer may require a different approach. So clinical case-based management will help improve the outcomes in non-healing corneal ulcers. Thank you for your kind attention, and I hope I have justified the subject. If there are any questions for me, maybe I'm open for that.
Excellent presentation, ma'am. Thank you very much. Very nicely covered all the aspects of the non-healing ulcers, especially the drug toxicity is very important to be considered, especially with the fungal medications and unnecessary usage of fungal antibiotics as well as the antivirals in one single case. We need to be a little bit more judicious in that. And also the importance of tarsography, wonderfully displayed there. And when do you consider amniotic membrane, ma'am, in such a cases?
Especially, I could not put you because I was, last hour I was just finishing in between Caracon and this PD. But for BKC, definitely, shield ulcer, when it is grade 3, you would like to scrape that surface and put in an amniotic membrane to reduce the scarring in those cases and allow the utilization much faster. The cases where there is no perforation, you can definitely use, neurotrophic cases, you can use an amniotic membrane along with tarsography. In chemical injuries, you would like to use, amniotic membrane, obviously. And there are people who also promote, using amniotic membrane in presence of infection. But personally, I do not prefer to use, amniotic. Tarsography works wonderfully well, which is very less utilizable by most of the, cornea people and general ophthalmologists as well. So it is a wonderful tool to use. You can use it for a couple of weeks and you can reverse and patient will be absolutely fine.
True.
So I am kind of a proponent of tarsography.
Yeah, it has worked wonderfully in my hands as well.
Absolutely.
Thank you very much. It was delight hearing you. I
Thank
think
you for
because
the
of the
opportunity.
paucity of time, we can go to the next presentation.
Sure,
Krishna,
sure.
please, Dr. Tanuja's present.
Hello, everybody. I'm Dr. Tanuja, and at the outset, I would like to thank the KOS for giving me this opportunity to be able to share my views with the esteemed audience. So my topic is peripheral ulcerative keratitis, and so peripheral ulcerative keratitis is an ulcer in the peripheral cornea. So why are we also worried about it? What is the uniqueness of this peripheral ulcerative keratitis? Most often than not, it is non-infectious keratitis, usually associated with autoimmune diseases and collagen vascular disease. So it requires extensive workup and systemic management. Peripheral cornea is unique in that it is closely associated with the conjunctival vessels, and so there's more access to the immune complexes or the antibodies which can reach the corneal antigen and in the peripheral cornea and react. So coming to the dilemma of any peripheral ulcerative keratitis, whether it's an infectious, begins with whether it's an infectious or non-infectious. Usually the signs like surrounding cornea, which is much more hazier and edematous and infectious. You would not see the same thing in a non-infectious. The surrounding cornea is usually crystal clear. But of course, the ultimate management diagnosis will be on by microbiological examination. So first exclude an infectious keratitis. And once we have diagnosis non-infectious keratitis, I would say the dilemma continues or begins. So which is the autoimmune disease is what we need to identify, for which we need systemic examination and investigations, and which also requires systemic management. For an ophthalmologist, when you see a peripheral ulcerative keratitis, the most important thing is to differentiate it between a because of collagen autoimmune diseases or collagen vascular disease and Murren's ulcer. Okay, because Murren's ulcer is not associated with any of these and requires more of a ocular management. So differentiating it from Murren's ulcer would be by signs like pain is much more severe in Murren's ulcer. The ulcer extends deeper in case of UK, whereas in and perforates faster, whereas in Murren's ulcer it extends circumferentially and centrally before it extends deeper and perforates. So associated involvement of sclera, lid, dry eye, uveitis, all these point towards a PUK, and you're probably dealing with a UK. Again, progression, we've already said that a PUK may be associated with may extend to this adjacent sclera, causing scleritis, necrotizing or non-necrotizing can cause conjunctivitis, whereas Murren's ulcer is limited to the cornea. And in PUK, you might see more perforation at the earlier stage compared to Murren's ulcer. It's very important to recognize PUK, but once you recognize, you exclude Murren's ulcer and you recognize the PUK, you need to know that your treatment is only one part. Ophthalmologist plays only one part of the treatment for the patient, because systemic disease recognition is more important, and because if you don't recognize it early, patient has a mortality of almost 25 to 40% in 5 years. So most of these patients have an established or diagnosed with AID, and after 10 to 15 years after diagnosis, they present you with a PUK. But you need to be aware that 25 to 30%, so that's a significant chunk, may be presenting for the first time with some signs, with eye affection, and the ophthalmologist plays a very crucial role in diagnosing the autoimmune disease. So this requires a very good history to include elicit history of other system involvements, ocular examination which has to be complete, both anterior and posterior segment, to rule out any posterior segment anomalies, and dry eye test, because most of them are associated with keratoconjunctivitis sicca. Systemic examinations and investigations, which include a preliminary test should be sent whenever you see a PUK of CBC, ESR, RA factor, EME profile, urine routine, and chest X-ray. Now, this is a quick, this one to help you diagnose PUKs associated systemic disorders. If you see PUK with ciliadenitis or that dry eye, and associated with interstitial lung disease with joint pains. We're probably dealing with rheumatoid arthritis, and the treatment and the diagnosis will be established by RA factor, but you should also be aware that RA factor negative rheumatoid arthritis can also be present. If it is associated with pericarditis, pleuritis, synovitis, alopecia, and scleritis, we're probably dealing with SLE, and anti-SM and anti-RNP are the diagnostic tests. If you're seeing any kidney affection, upper and lower respiratory tract infection, or vasculitis, ulcers, non-healing ulcers, you're probably dealing with vaginous granulomatosis. C-ANCA is a diagnostic test for vaginous granulomatosis. So once you diagnose a PUK, establishing the cause of the PUK is very important. This is first half. The second half is the management. Here you have to follow a step ladder approach. The local treatment would be a lot of lubricating drops. Topical steroids are questionable. Oral steroids are definitely an are the treatment of choice, but topical steroids, you have to be very careful, because if there is thinning, it might increase the melting. So you have to be very careful while you're prescribing topical steroids. N-acetylcysteine and medroxyprogesterone drops can be given. Collagenase inhibitors like doxycycline and vitamin C. Conjunctival resection. Again, it has a role to play in case of Moran's ulcer, but in case of PUK, it has not been very well established. But if there is extensive corneal melting, this can be tried. Systemic immunosuppressives are the mainstay of treatment. So initially, you have to start off with oral steroids. If the patient is not responding or has side effects due to steroids, which is 1 milligram per kg, you have to shift over to immunosuppressives like methotrexate and azathioprine. If they're not responding to those also, then probably cyclophosphamide. In case of rheumatoid arthritis, cyclosporin is the first choice. Additional surgical procedures like if there's melting cyanoacrylate glue or fibrin glue and amniotic membrane or lamellar grafts will also be needed to salvage the eye. Only once the active inflammatory stage is reduced and the disease is under control, only then visual rehabilitation should be attempted for these patients. So the initial treatment, initial concern will be treating them with systemic immunosuppressives, and during that whole time, salvage the eye, protect it, and don't let it go beyond your hand so that there's no melting. So preserve the globe as much as possible, and then once the inflammation is under control, then you can try the rehabilitation levels. So this is one of the cases where the same patient, right eye, came with peripheral ulcerative keratitis, which was involving around half of the cornea, whereas in the left eye, he had almost only 1/3 of the cornea was left, and the rest of the cornea was thinned out and with a perforation. So we went ahead and did conjunctival resection for this patient, and also applied glue for the right eye. For the left eye, we did almost a crescentic graft, trying to preserve this cornea as much as possible. Surprisingly, this patient did well and had a 660 kind of vision. But though he was diagnosed with rheumatoid arthritis and was put on immunosuppressives, he was very non-compliant, discontinued, and finally after 1 year ended up, this is after 6 months, he was like this, and after 1 year, he ended up like this with the further progression. And then we had to, at the second stage, we actually had to do a total keratoplasty for him. So what you need to remember in PUK is it's not one person's, one doctor or one clinician's disease. It requires a team management, an ophthalmologist and a physician, an immunologist is required for the management of these conditions. So the take-home message is for us as ophthalmologists, first differentiated from Moran's ulcer to a complete systemic workup. Sometimes repeated investigations are required, and the systemic immunosuppressants are the mainstay of the treatment. So just treating the eye and thinking, you've stabilized the eye is not enough for these patients, because if you don't start them on systemic immunosuppressants, and then the mortality and morbidity is very high. So a team approach is mandatory in diagnosis and management of these patients. So the PUK is not a disease of just for the ophthalmologist to see. A collaboration with the intensivist is very much needed in these patients to reduce the visual morbidity and also to reduce mortality in these patients. Thank you very much.
Thank you, Dr. Tanuja ma'am. It was an excellent presentation.
Thank you, sir. If there are any questions, I'll take them now.
I think we are almost coming to the end of the session.
Okay.
4:30 we need to give the hall. So I had a very brief presentation. So I'll just present that. Can you see my slides?
Yes, sir, we can see.
Okay. Yeah, this is regarding the tips and tricks of keratoplasty. I'm sure the audiences are the excellent surgeons. So it will be more helpful for beginners or the postgraduate students who started doing keratoplasty. Definitely these few tips may help them. So the first tip number 1 is the maintenance of intraocular pressure. So whenever it's applicable for even for normal keratoplasty, penetrating keratoplasty, any patch graft we are doing. Before that, we must make sure that intraocular pressure is under control. And in advanced this infectious keratitis patient, when we are doing PK, it's only the digital measurement that is helpful. So we should get a hang of how the intraocular pressure by digital feels like, and by all the means, with the topical medication and systemic medication, even with the IV mannitol just before the procedure, should make sure that intraocular pressure is under control, or it should not be high before we proceed with the graft. The tip number 2 is we should take a good donor tissue. Always therapeutic keratoplasty means you take some left out tissue or some old tissue after a few days of usage, or which is not used by anybody else. No, I think whenever you are planning therapeutic keratoplasty, I think now the donor tissue is not an issue right now. So take a good tissue so it will survive in longer run. The tip number 3 is just before you do the trephination, make a side pour, and with a normal saline, wash the anterior chamber. So you probably wash out all the hypopyon. Then you'll be able to observe the extent of the infiltrate better in advanced keratitis. So then we'll know at margin of the ulcer, and you will trephine the size of the trephination. You can judge in a better way. The tip number 4 is if the graft is large, if the infiltrate is larger, you're taking a larger graft, making a larger trephination, take a larger donor. So anterior chamber depth will be maintained in a better way, and suturing will be better. It will not be too flat, and chances of glaucoma will be little less. Tip number 5, do a peripheral iridotomy. Always do a peripheral iridotomy in all these therapeutic penetrating keratoplasties, and with the viscoelastic, with a fine cannula, you clear the angle of the anterior chamber, you swipe with the cannula, or you take a iris suppositor and clean all the material from the angle of the anterior chamber. Tip number 6 is when you put a tighter suture, because it's a edematous cornea and you are also taking a little compromised donor, the cornea will be little edematous, so the suture may become loose, so it may start leaking, it may get infected, all the complications of loose sutures. So make it a little tighter suture is always better. So to make a tighter suture, probably select a little larger graft, donor graft, it will always be helpful. The last and the final is probably at the end of surgery, you may consider intracameral injection of an antibiotic or an antifungal if it is a fungal keratitis. So I think that will be my some tips for beginners who want to start with a therapeutic penetrating keratoplasty. Once again, I thank Dr. Elan, Dr. all the KOS scientific committee people for giving us this opportunity. With this, I think we are just coming to the end of the whole session. Once again, I thank all the speakers for taking out time and giving this wonderful talks. With this, I hand over the session or the hall to the next session. Dr. Paras or Dr. Anybody want to comment, they can comment.
Thank you, Dr. Vidya Shankar, and thank you all for having me here. Thank you.
Thank you.
Thanks, Dr. Paras, Dr. Vidya Shankar, an excellent session.
Thank you, Paras ma'am.
Thank you. I mean, you can get in touch with me, no problem. I'm listed on that WhatsApp group.
Yes, ma'am. I had a few doubts. I'll definitely contact you.
We'll communicate, no problem.
Yes, ma'am. Thank you.
Yeah, enjoyed.